about to, which is now being recorded and will be posted online afterwards. Again, that email for the introduction is for anything that we can't deal with in the meeting is herc.info@oha.oregon.gov. And since I didn't say it on the recording, I'll just say again, this is the September 11th, 2025 Evidence-Based Guidelines Subcommittee meeting, and we do have a quorum. All right, Linnea, the conflict of interests declaration.
So this is really important. So do anybody here have any conflicts of interest? And hopefully you've completed any conflict of interest forms that are required for the committee as well. And then I think we're on to review of minutes. Is that correct?
That's right.
So if you go, I think, to your packet, it's on page 4. We need to review the minutes, and there are a couple of votes that we need to take. So hopefully everybody can see those. Anybody move to approve the minutes from the previous meeting?
I move to approve the minutes from the previous meeting.
Thank you, Larry. Is there a second?
Second.
Thanks, Devin.
All right. Call the
Call
roll.
the roll. Yep.
All right. Mimi McDonald.
Here. Yes.
Yes. Yeah. Devin.
Yeah.
Abby.
Here.
We need a yes or a no.
Yes.
Okay. Thank you. Larry.
Yes.
Kat.
Yes.
Leslie.
Yes.
And Linnea.
Approved.
All right. So it is passed. The minutes are approved unanimously.
Great. And then we're going to move on to our staff report. So thank you.
Yeah. So I do have a few updates today. First of all, today will be Leslie's last meeting with us at EBGS. Thank you, Leslie, for many years of service and representation. The governor has nominated Matt Serres of the Oregon Council on Developmental Disabilities to replace her on the commission. And I'm hoping he'll be able to serve on the subcommittee as well, although that decision needs to be made by HERC. So wish Leslie well and give her some Thursday afternoons back in her life after many years of service. So thank you, Leslie. Did you want to say anything else?
I just wanted to thank everybody. I think that the work that the HERC does is so important, and the piece that I really always pay attention to in Jason's introductions of all of our meetings is that the work done here impacts 1 million Oregonians. That's why we're all here. And I've always been so impressed with how each of you shows up, knowing that responsibility and really looking to do what's best for Oregonians and really weighing a lot of those values that all of us want to see in our own lives, but also that every human deserves the right to access to healthcare. So I just want to say thank you to everybody. Keep doing what you're doing. I do look forward to having my Thursdays back, but I will think of you. Maybe. I'm just
Maybe.
kidding. It'll be
Thank you.
great. And I really have appreciated all the connections and just seeing the incredible passion that comes from this group, I think is really important. I am not a doctor, and so it's always been a great, I guess, exercise in learning more about how the medical system works. And I think it's made me a better person that does the policy work I do for people with developmental disabilities by learning from all of you. So thank you. And I definitely look forward to seeing what all of you get up to next. Thanks.
All right. Thank you. We do have some other membership changes as well. Adrian Irwin's her term is also ending at the end of the year, and Jeff, so not until after the November meeting and before the January meeting. Jeff Fortner, who's a professor at Pacific University and also does pharmacy work in several retail settings in the Portland area, has been appointed to replace her, again, subject to Senate confirmation. And the plan is for Adrian to continue to serve on the Value-Based Benefits Subcommittee. Linnea Lindsay's work term is also expiring at the end of the year. We're still looking for a replacement for her, and she'll continue to serve until replaced. And even after her term ends, she'll continue to chair EVGS until, because there's a longer term limit for subcommittee membership. So thank you for that. I should also say Stacy Geisler, our dentist on the commission, her term is up and she was nominated for reappointment. And those hearings, I believe, will be on September 29th. So any questions about membership? All right. And then next, talk about the benefit update project process. As I said, I believe at our last meeting, the legislation related to that did not carry in the legislature. Nevertheless, we are doing a benefit update project work group, and our very own Kat Livingston is chairing that. And then Mary Beth Angrave and is also serving on there. So Herc is well represented on that group, and our staff is participating as well. We've had 2 meetings so far. There's another one, I believe, is it next week, Kat? I think that's coming up. Those are public meetings. If you need help finding those, feel free to email us. And had a robust discussion. One of the issues that came up, a lot of what's happened so far has been like introductory. But one of the issues that came up in the last meeting was, in Herc's original role in tight budget times was to rank services and have a funding line and have a role in deciding what needs to be cut in those challenging times when budgets need to be cut, and they always need to be managed, even in the good times. We want to have good stewardship. So I think the work group wants to explore that topic a little more. The role would have to change because of the end of the waiver. So that'll be a matter of ongoing discussion, and we'll keep you up to date. Kat, anything you wanted to add about that work?
I thought that was an excellent summary. Yeah, that was a really interesting discussion that we had about how we can continue to leverage Herc's expertise and the use of evidence to really try and make these population level decisions with the funding line away. And there were some ideas turned out that I think the group will need to explore in more detail to really understand, because in the context of potential future pretty significant budget limitations, which seem very foreseeable, it would be really nice if we can continue having this clinical lens, this evidence lens, so that we're continuing to make decisions that benefit the population based on evidence, and this thoughtful group as well as the other subcommittees in Herc.
Right, thank you. Any questions or comments about that? All right. And as if on cue, as we're doing this work, we've had, if you've been watching the industry press, there have been some issues regarding budget coming up recently. And I have a few talking points that I've been given permission to share in this group publicly. This has been shared publicly at the Oregon Health Policy Board, so I'm not breaking news here. But I thought you should all know, it just underscores the importance of that stewardship aspect of what we do, as well as what's coming over the next couple years. So over the last couple months and currently, OHA has been working with our coordinated care organizations to negotiate rates and contracts for 2026. So this is coming up just in a couple months. Those contracts are not signed as far as I know. Numerous changes at the federal level are creating a different healthcare landscape. If you've been watching any news, you've probably heard some things about that. We expect new requirements, more paperwork, and fewer funds to work with. We acknowledge this is a tough starting place, And like every corner of healthcare now, OHA recognizes that the CCOs are also facing many challenges. As we have these discussions between OHA and I'm not, when I say our, I don't mean me, I'm not involved directly. OHA has listened to requests from CCOs regarding rates and contracts for 2026. OHA has worked hard to address the CCO needs while minimizing disruption to our members, while acknowledging the resources needed to deliver services to OHP members and aiming to be a good steward of state dollars. There's that word again. OHA has proposed increasing CCO rates. One central part of that proposal is to reduce administrative burden and reporting requirements so that CCOs and OHA can spend more time improving care for members. So that's a little bit of a shift that goes on beyond just the, what's covered, what's a benefit. Last week, OHA sent a proposal to CCOs that moves CCOs to match the rising costs of healthcare, proposing CCO rate increase beyond what was offered in August. Or I'm sorry, this is based on additional data received since early August. Apparently, there was an earlier rate. Total CCO expenditures per member grew by more than 10% between 2023 and 24. This is in line with the overall cost of healthcare we've seen in all sectors. This would put capitation rates from 6.8% statewide up to 10.2%. So that's much higher than the cost growth target of 3.4% for those of you who track such matters. OHA will continue to meet with CCOs in the coming weeks. As always, OHA will work to identify solutions collaboratively and meet the stated goals and specifics in the contracts to serve OHP members. And this is the start rather than the end of what we intend as an ongoing dialogue to ensure sustainability for the Medicaid program amidst these unprecedented constraints. And there'll be more news coming, and I'm sure some ongoing discussions. So any questions or comments about that? So I don't think it changes what we do. We're still governed by the evidence and doing what's right for our members. It just underscores that the importance of good stewardship and some of the stresses that are on our members and our providers and our CCOs in this time.
Does the compact between Oregon, California, Washington, and Hawaii have any bearing or anything to do with what you just said?
So I think, Larry, you're referring to this compact between four Western states to develop vaccine policy to address potential difficulties in accessing vaccines because of some things that are going on back east and across the nation. And Ariel is on a team that's working on that. And I think they've had their first meeting. What I can say for Oregon Health Plan is vaccines are covered because of the work HERC does. The existing guideline note will allow coverage of vaccines covered by the Oregon Vaccine Program. So that's a state group in addition to those covered by ACIP, which is the national group that meets next week and might change the recommendations according to what we're hearing in the news. So we don't expect any changes. We'll monitor what that group is. Ariel will be our liaison of staff, and we will keep you all informed as necessary. And I know the governor's office is engaged as well, and I'm sure there will be more news forthcoming soon. But I don't think it certainly should not affect the EBGS's work. If it affects HERC's work, of course, we'll let you all know as soon as we are able.
All right, thank you.
Anything else about that? Okay. I guess I wish I had ended with the good news of membership transitions, but that is the update I have. So with that, I think we can move on to the BUP I'm sorry, yes, the benefit updates project topics.
Great, thank you, Jason. So just to kind of update you all on where we are in the benefit updates project, we, as staff, had our goal was to make all of the major decisions about BUP by our November HERC meeting, and I think we're still on track for that.
And this is page 14 of your materials.
Thank you, Jason. We have a couple of follow-up issues that are coming, and if we make decisions on all of these topics today, this will be the last you see of BUP. So, and then you may have a few things come back next year for some cleanup, but we may just take those straight to HERC. So, we're making really good progress. So the first topic that's coming back to you is one of the gynecology topics. There was a question when we discussed this at our last meeting about vulvar polyps. These are essentially skin tags in the female genital area. There was a question about whether we would cover removal if there was a question about whether this actually was just a benign skin tag. ACOG doesn't recommend removal at all. It's not listed as a recommendation. Staff have found that there is a D code, a different diagnosis, which would be a neoplasm of uncertain behavior that would be used that's on a covered line or would be in it would be in a code grouping in the future paired with excision CPT codes. So we're pretty comfortable that if we place a polyp of vulva on evaluation and management, anything that a clinician is uncertain about what this actually is could be excised. Any questions? And Jason, do we need to vote on each, or do you want to try to vote on them as a group, or how do you want to do that?
We can vote on them as a group if you want.
Um, I would recommend voting on them as a group plus one. There's one additional topic that snuck into your agenda because it's highly related to a BUP topic, but it's actually a new CPT code. So so the two BUP things I think we could vote on as long as you're comfortable with that. So the other BUP follow-up item that you all wanted to discuss further was hirsutism and hair loss. As a reminder, hirsutism is hair that is too prominent or in an area that wouldn't be typical. And it can be a result of many different things. It can be hereditary. It can be from something like polycystic ovarian syndrome. It can be a side effect of medications. And then the opposite would be hair loss conditions. Some of this is common as particularly males age, they can have hair loss. Then there are some autoimmune disorders like alopecia totalis and alopecia areata, which are autoimmune diseases and can cause hair loss in all over the body. In the universalis diagnosis, totalis could be like losing eyebrows and eyelashes as well as the scalp hair. Hypertrichosis is just a localized area with too much hair loss. When we discussed this at June, there was an interest in confirming that we are constrained about treating autoimmune or inflammatory hair loss conditions, particularly as these can lead to medical and psychological issues. We checked into with our leadership, and this would require us to have a change to our state plan with that, which is a contract that we have with CMS.
That's for the medications, right?
For the medications, exactly.
Yeah. Okay.
Yeah. So, and currently we're constrained with medications. We currently only cover wigs because it is in our benchmark plan for the ACA Essential Health Benefit for hair loss due to chemotherapy or radiation, so cancer treatments. And then the third piece we were asked to look at was electrolysis and laser hair removal. We can contract with those types of licensees if they are under medical supervision, but there's an extremely limited supply of these providers. So what we have determined is that HERC has discretion to add coverage for non-drug treatment for hair loss and hair growth. Um, wigs must be covered for hair loss related to cancer therapy. Um, you could decide you want to expand that if you would like to. There would be a fiscal impact for that. And that HERC does not have the authority to add medications for hair loss. And then kind of moving on with the same idea with wigs, um, I queried other state Medicaid programs. They're all essentially only covering wigs for cancer-related hair loss. New York has defined it a little bit more broadly. They're basically calling it medically induced hair loss. So it would be essentially chemotherapy, but if there was a non-cancer reason for the medication, they would cover it. Um, and then private payers um, that I surveyed are only covering treatment of unwanted hair, so electrolysis, et cetera, when provided as part of gender affirmation, and they're only covering wigs for cancer treatment-related hair loss. All private payers were paying for medications for autoimmune and inflammatory hair loss. And then there was also a question about validated scales. If we wanted to cover some type of alopecia, is there a way to do a validated scale? And there is a scale that was published in 2022. Um, so a lot of this you've seen before. So essentially, in summary, wigs are not covered by other Medicaid or private insurers for other indications other than chemotherapy and hair loss, and that is the staff recommendation to continue to cover wigs only for cancer-related treatments. Drug treatment for autoimmune hair loss is excluded by administrative rule. Um, we we currently recommend placing these in the evaluate. So this would be like the alopecias, alopecia areata, alopecia totalis, in the evaluation and medical management code grouping that would allow office visits and appropriate diagnostic services. It would not really affect medications because, again, we would have to apply for a special waiver with CMS, and that would be a process. And so that would continue, even though we've been saying that everything on evaluation and medical management would have medications. In this case, those medications would probably have just a hard stop. This is not a covered service. And then as terms of hirsutism, private payers and Medicaid only appear to have the same coverage we do currently, which is for gender affirming care. Given the lack of coverage for things such as eyeglasses and dental crowns that we previously had put in the covered region, it just seems a, a little bit of an. We would prefer to start really advocating for coverage of some of these other optional benefits before staff would recommend coverage for hirsutism. So the staff recommendation is to place the ICD-10 codes for hair loss and hirsutism in the code groupings that would essentially be evaluation and medical management, except for a couple that are on complications. They would have a guideline. These would be the hair loss for wigs. And then there would be the guideline for wigs would just essentially convert over to be a coverage guideline with the typical changes about when medically necessary instead of on lines. And it would reflect that it's only due to chemotherapy or radiation, and that would kind of clear up why there's some of these acute radiodermatitis. They're only on that line to represent the hair loss. They're not there for other reasons. And then wigs would the wigs would stand 421. The electrolysis would stand just the current lines that it's on, which is mainly pre-op and gender affirming care. Questions about all of that? Kind of all the little bits and pieces. So it's not a nicely packaged summary. It's all the little bits and pieces that we had left over.
I'm sorry to interrupt, but Larry's having some internet trouble, and we are low on internet support today. Does anybody know how to find the phone number? Um, I will.
I think it might have been in the email that you get when you register for the Zoom link. I'm not able to look, but I think it might be there.
Thank you. I'll look there.
Oh, yeah, it's
And
just
we
a
still have
routing
quorum.
number.
We can continue, but um,
Okay. Do folks have questions for me about any of the hirsutism or hair loss, or have anyone want to discuss any pieces of it? If not, if you're comfortable with the staff recommendations on vulvar polyps and these two hair issues, if you're ready to vote, we could entertain a vote.
I move to approve the staff recommendations as presented.
I second that motion. This is Mimi.
Can you call the roll, Jason?
yes, just a moment. And we'll have to get.
I can, if you'd like, Jason.
That would be great. I'm going to get Larry back into the meeting. Thank you.
Sure. Okay. Mimi McDonald,
Approve.
Devin,
Yes.
Kat Livingston,
Approve.
Abby Kahn,
Approve.
Leslie Sutton,
Approve.
and we know Dr. Lyon is out, and so finally, Linnea Lindsay.
Approve.
All right, that is 1, 2, 3, 4, 5 votes.
And Larry, are you able to speak now?
Okay, I
Great.
think I'm unmuted.
Okay. Did you want to vote on those topics?
Yes, but I'm sorry. Can you repeat the what we're voting on? Because I didn't catch that.
That was the vulvar polyps and the staff proposal regarding hair loss and hair growth treatments.
And that's just to maintain the staff recommendations.
Correct.
Correct.
Great. I approve.
Okay, great. So we will record that. And I think I heard everybody was in favor of that. Is that correct?
That is correct.
Great, thank you. All right.
So we have one additional topic, which is tangential to your BUP, and that is scalp cooling to prevent hair loss during chemotherapy. These are anticipated new CPT codes out this fall. They have been written about by industry. They're in the AMA minutes when they talk about CPT codes, but the actual codes have not yet been published. So this is a little bit of a preemptive strike. We just have as you can see, it's like 9XX01. Those are what were published in the AMA RUC subcommittee minutes. So
This
there's
is
no
page
official
24, by the way.
there's no official codes. And we are pending actually seeing the final code wording. So what I was hoping for this group is that we could talk about this, get it approved or not approved, whatever, however you feel in concept. And then when this comes to the actual HERC in October, they'll have all of your conversation and your recommendations, even though it's not technically you're not doing like a final approval. Hope that makes sense. We're trying to get a little ahead of the CPT codes. So when people have certain types of chemotherapy, they can lose hair, particularly with certain regimens. There are these cooling caps. They look kind of like a helmet, and they have very cold water that goes through them. And the theory is that it sort of constricts the capillaries, reduces blood flow to the scalp hair, and prevents the chemotherapy from getting in and basically causing damage or causing the hair to stop growing and shed. These are approved. They are currently covered by Medicare. It's about $2,000 per treatment, and each chemotherapy treatment. And this technology has also been adapted for things like hands and feet for peripheral neuropathy, but these codes, as far as we can tell, are going to be specific for the scalp treatments. We've never looked at this before. We do cover chemotherapy for a large variety of indications. There was a systematic review published in 2018. One of the two authors received significant funding from industry. They noted 10 RCTs, most single center. Six of the studies compared scalp cooling to no cooling, and then the other three compared one type of cooling system to another. They were rated to be at unclear risk of bias. There was a significant effect of scalp cooling and reducing alopecia, which they defined as patients requiring wig wearing. So the authors report that there was almost a 50% reduction in the need for a wig with this type of treatment. Only one study reported quality of life assessments, and there was no statistical difference on any of the instruments between groups that had the cooling and did not. The main reported adverse event was headache. Their grade assessment was that this was moderate. And the authors concluded that scalp cooling had a positive effect on reducing the amount of alopecia. And there was one RCT published in 2017 that was not included in that, or it was included, I'm sorry, in the 2018 systematic analysis. That was the one study that did report quality of life outcomes. And they actually found that there was no significant difference in emotional and social functioning. And they actually noted in their discussion section that there was actually almost a trend toward it being worse with the scalp cooling, and they thought it was because if you underwent scalp cooling and you lost more hair than you anticipated, there was a worse emotional and social sort of reaction. And then another study in 2020 I was really trying to hone in on quality of life here. They found inconsistent evidence in studies on quality of life. And they also noted, again, that quality of life can be worse when the scalp cooling doesn't work as well as it was anticipated by the patient. Looking at expert guidelines, NCCN's breast and ovarian cancer guidelines both mention scalp cooling, and they both mention that it can be considered. Looking at other solid cancers, there was no mention at all of scalp cooling. Private payers typically feel like scalp cooling should be part of the overall chemotherapy administration codes and shouldn't be billed separately. Medicare does pay for this if it's used for chemotherapy-induced alopecia prevention. So in summary, scalp cooling appears to be moderately effective at reducing hair loss caused by chemotherapy for solid tumors, but that there's really no evidence, kind of conflicting evidence of whether it affects quality of life, and it may even worsen quality of life scores if the scalp cooling doesn't work as well as anticipated. NCCN guidelines just lists this as a consider option. Medicare does cover this. Private payers are mixed. There are two states that responded to my request, New York and Louisiana, that have legislative mandates for coverage. States that do not have legislative mandates that responded, which is just a small number, reported they're not covering scalp cooling. So the staff recommendation is to not cover scalp cooling because it has insufficient effectiveness for clinically important outcomes such as quality of life. Questions for me, Devin?
I mean, I agree with this staff recommendation, but maybe I wonder if it's for different reasons, though. So from a stewardship perspective, since Jason so nicely introduced the session here today, I guess we'll have to make some decisions about things that are cosmetic versus health outcome related and so forth. And I just looked up out of curiosity the proportion of patients with chemotherapy-induced hair loss who are able to regain hair growth, and it says 98% on at least on open evidence search. So I think both for the reason you outline in terms of the quality of life outcomes, and maybe that's part of the reason is that you're, you know, even though I understand it is a big deal. Most people regrow their hair. So, anyways, I support the recommendation.
Would you prefer that the rationale for non-coverage, instead of being insufficient evidence for things like quality of life, would you want it to say something like cosmetic treatment?
Well, yeah, I mean, I don't know. I guess I'm just bringing it up in terms of if we want to leave like a path of consistency around, right? I mean, these are really expensive treatments, and it is essentially cosmetic. If it was cheap, I don't think it would be a big deal, but it's not. I don't know. I mean, I think that is part of the rationale, whether we want to state it or whether we think it's captured in the idea of quality of life. I don't know, but I do think it's useful to be consistent. So if there's other things that are cosmetically related and we're going to kind of consistently not cover cosmetic things, I think that's an understandable line to draw.
So rather than putting it on like excluded services, we could just say it's excluded, which is outside of the benefit package, like we do for some cosmetic, like, for breast augmentation, for routine kind of cosmetic purposes is outside of the benefit package, that kind of thing.
I-
Devin,
I-
I see their hands up, but I'd like to address something Devin said first. You make a good point because the administrative rule, if you could go up, Liz, that governs these services for us is that that OHP does not cover services to improve appearance except when approved by her, or except for exceptions made by her. Where is that? It's quoted in there.
Yeah.
And so maybe we could just decline to make an exception. Is kind of, I think that's what you're saying, Devin. Is that right?
I think that you've phrased that much better than I did. Yeah.
Well, thank you, administrative rules. But I see Linnea and Leslie have their hands up.
So I was going to respond somewhat similarly that the stigma around hair loss is there is stigma, but stigma around hair loss for cancer has been decreased for a lot of people. It's become normative in our society with people having chemotherapy for people to understand they're going to have hair loss. So I think it actually, the risk is if people like what we were talking about that if people have that expectation, oh, I do this thing and I'm not going to lose my hair, and then I do, that has potential harm because you created a psychological distress for someone. So I think that the opportunity and I really appreciate Devin you going back and saying 98% of people regrow hair, then it is temporary as well. So it's a temporary treatment for a non-clinical condition per se. It's a side effect of the medication, but it isn't a disease unto itself or a disorder. So I think that that has merit to not cover it. Just say we're not covering it, and I prefer that to excluding it because there may be a time, we never know. We always have this happen where 10 years later there's all this clinical implication for it that we don't have any evidence of it this time.
So Linnea, you're recommending the staff recommendation rather
I'm
than just
supporting it,
exclude for
and
cosmetic. Okay.
yes.
Yeah, I have a comment.
I'm
And
sorry, Leslie's it's next, Larry, and then
Oh.
we'll call on you.
Okay, thanks.
I had a question. I think that the way that the quality of life study language came out is just, it's not sitting well with me. This idea that you were hoping not to lose hair and you did, and that's where the harm is. I'm just curious why the studies weren't framed as far as the people who were worried about losing hair and didn't and were grateful for it. I mean, I think those of us that know people that have gone through chemo, one of the first questions that they ask when they're trying to grapple with it is, am I going to lose my hair? And then everybody's going to know that I'm sick. Are they going to treat me like I'm sick? And I think that it's really important to remember that. In this, I'm just a little bit, it just doesn't sit well with me how the outcomes were worded there, because I think there is a positive outcome for some people. The other thing I was wondering is, I know that this is about a specific device, right? Like a $2,000 kind of cap, helmet, whatever you want to call it. Aren't there similar ways that people can do scalp cooling that are not this particular device?
My understanding is there's been all kinds of things, even just like bringing in ice packs.
Right.
But it's things are the sort of most people have these machines now. They kind of circulate the ice or ice water.
And would the other options around, the ice or there are caps with like dry ice in them and things like that, are those covered? So is there another less costly option for people that want to do this that would be covered, I guess is my question.
I think under that administrative rule, if it's for the purposes of improving appearance, it probably would not be covered without an explicit HERC decision. Now, an ice cap might be relatively low cost supply that's in the hospital. I don't know. And if it is, it might be provided, but we don't have any policy on it.
Yeah, and if there's no specific billing code for it, we wouldn't be able to find out if it's covered or not.
Yeah, I would assume you would have found a billing code if there was one. So, okay, thank you.
Yeah, there is one for like ice pack therapy, but it's like a PT code. And I don't think we would have.
Yeah, that doesn't sound like it would fit.
Yeah. Larry, you had a comment?
Yeah, I do. Thank you. I want to go back to what I heard what Devin say, and that is we need to be consistent. On the one hand, if we are covering wigs for chemotherapy, then we could use the same argument that this is a cosmetic treatment. In the case of wigs, as opposed to scalp cooling, wigs are relatively inexpensive. We are entering a new time. We're going to wind up doing less with less, and I think the consideration of cost is something to think about. So I agree with the staff recommendation to not cover the scalp cooling.
Yeah, and thank you, Larry. And just the materials, from what we can tell from talking to the different analysts, we only pay $150 for a wig, which is a very low rate. So
Yeah.
far less than the proposed scalp cooling.
Yeah.
And the only reason that we cover the wigs is because under the ACA, we have to have at least the same coverage as what the state determines as their benchmark plan. And the benchmark plan that the state chose covers wigs for chemotherapy.
Yeah. The other thing is that this is potentially a very slippery slope, because if we start looking, oh, I had this operation, I have a scar. We talked about the keloids before. It's I don't think this is this is not the hill we want to die on.
Yeah.
So it seems like there's maybe two options. So one is keeping it as a staff recommendation, but just adding a little bit in there about it being high cost with no proven benefit or minimal benefit, versus if that other code group still exists, it could go into that one of doubtful clinical benefit and relatively high cost.
High cost and minimal. We could do high cost and minimal benefit. Okay. So as I mentioned before, this is not a binding decision because we don't actually have the codes yet, but this has been a really helpful discussion. And what I will do is I'll summarize this discussion. I didn't hear anyone disagree that we should cover this type of treatment. It sounds like the big debate is how to operationalize that, whether we should just exclude or whether we should do E2, and if so, what the rationale should be. So staff can mock some things up to,
Kat, weren't you saying E1?
or we could do E1.
That's be
What
the,
No,
what is
E1
E1?
is things
E1
with
and
benefit.
E4.
I don't think this has benefit. I don't think they've been shown to have
Okay.
benefit other than. I'm sorry,
yeah.
Kat. I just cut you off.
E1 is for things that are not least costly. So like Cologuard is in
Oh,
that category. They're effective, but they're not as effective or as cost effective.
okay.
Oh.
Then if you need a motion, I could move to approve the staff recommendation with a slight modification within the rationale to include a cost reference.
I second that.
Leslie, you have your hand up.
Yeah, I do. I just also wanted to put in if this has had any sort of analysis for equity related to cultural beliefs around hair, because I do think that that is something. Hair does grow back, but it also can take years to get the way that it was before. And for some cultures, the hair has a lot of history to it. I'm just wondering if anyone's looked at it from that angle.
I,
I did not run across that, Leslie, but there may be a more of a literature that I'm not aware of.
Okay, thanks.
I'm not comfortable going down that path in terms of looking at hair, in terms of what cultures and groups value hair, and should that be a deciding factor. I am not comfortable at all with that. I think that I'm looking at this from a lowest common denominator type of perspective. And I'm also looking at this from a anticipated future decrease in funding for healthcare overall. And the reason why I'm uncomfortable with looking at this from a cultural perspective, different groups, we've already seen a question come up regarding funiculectomy in one group versus another group, and I'm not comfortable making exceptions.
Thank you, Larry. So we have a motion and a second. Is there more discussion before I call the roll?
So I also heard a thought of a modification to the staff recommendation to add to the rationale, and high cost or semicolon high cost, something like
Yeah,
that.
that was Kat's motion.
Okay.
It would be higher cost than alternatives. Would that be what you would say, Kat?
Yes, it is definitely higher cost than a $150 wig.
Okay. Any more discussion? All right, with that, I'll call the roll. Mimi,
Approve.
Devin,
Yes, approve.
Abby,
Approve.
Larry,
Approve.
Kat,
Approve.
Leslie,
No.
all right, Linnea.
Approve.
Okay, so the motion carries. 3, 4, 5, 6. Yeah, 6 out of 7. So that approved. All right, thank you.
And I just want to acknowledge again that when the final codes are published, there may be a slight alteration. And if there's anything significant, I'll let you all know. Wonderful. You guys have powered through your benefit updates project and ancillary type of things. We can move. Leslie, did you have a question, or is your hand still raised?
Oh, I forgot to lower it. I'm sorry.
No worries. Thank you. Are we ready to move on to the reconsideration again of the hypoglossal nerve stimulation coverage guidance?
Please move ahead.
Thank you. Liz, if you wouldn't mind putting up the slides. Awesome. So I'm Marcus Bachhuber, and I'm a clinical epidemiologist with the Center for Evidence-Based Policy. I've met y'all before, but just to reintroduce myself, and I'm here to present an update on hypoglossal nerve stimulators for EBGS. Next slide, please. So just a reminder, the Center for Evidence-Based Policy, we're contracted by OHA to carry out systematic evidence reviews. We perform these reviews using widely accepted and rigorous methods, and we carry out the evidence review according to the scope assigned to us by HERC. If we have questions or clarifications, we work with HERC staff, and we don't provide the evidence, we provide the evidence review only and do not recommend any of the coverage decisions. Next slide, please. So this is our team, our research director, Dr. Val King, Shauna Durbin, our senior systematic reviewer, Courtney Cooper, Jen Ryan, and Janice Gellinger, our research associates, and Jamie Hoffman, our project coordinator. So if you hear me calling those names out, that's who I'm talking to, not to myself. Thank you. We have two HERC-appointed experts. You've heard me introduce them before, and again, just want to say how grateful we were to work with these folks. Dr. Derek Lamb, a professor of ENT at OHSU, and Dr. Lou Libby, a sleep medicine specialist. And I understand that they are either on the call or planning to join the call today. Next slide, please. So we've heard a lot about sleep apnea in the past few months. So just to take a moment to reorient ourselves to where we are today. So this is an update of the previous draft coverage guidance on hypoglossal nerve stimulators for OSA. We presented this a coverage guidance a year ago, and at that time, EBGS directed us to update the search, update everything in a year, and represent it along with any changes back to EBGS. And there was a separate coverage guidance on OSA surgery that was approved at the HERC meeting in June. So that was a separate coverage guidance that's over and approved. This is now focused only on hypoglossal nerve stimulation. Next slide, please. So for our for our update this year, we reviewed FDA approval status for all known devices. We searched for and assessed new eligible studies. We searched trial registries for new ongoing studies, and we looked at the previously identified ones to see if they published. We reviewed all the guidelines that we found before for updated recommendations, and we searched for any new guidelines published. We also reviewed payer policies for any changes in coverage and coverage criteria. And then we contacted the HERC-appointed experts for industry developments and new studies that we may have missed. Next slide, please. So just to give you a little bottom line up front here, here's what we found. And as I present to you the remaining sections of this presentation, I'll weave these things in, but just wanted to give you an overview up front. So for the regulatory status, we didn't find any changes to the current approved hypoglossal nerve stimulator or its recall, which we'll talk more about in a few slides. There were no new device approvals. We found 3 new included studies around serious adverse events, but those studies didn't really add any new information. They weren't for a longer follow-up time than we had before. They didn't look at serious adverse events that we didn't already have information on previously. So there was no new information from those 3 new studies. For ongoing studies, we didn't find any publications of previously identified ongoing studies, and we didn't find any new ongoing studies. No recommendation changes from guidelines and no new guidelines, and no changes in coverage or coverage criteria from payer policies. Next slide, please. Okay, so we're going to go through a little bit of an abbreviated presentation here since we presented this a year ago, but if you have any questions, feel free to just stop me during the presentation. We have a lot of the detailed information in the supplemental slides and be happy to go over that, but we're going to take it a little bit higher level than we did last year. Next slide, please. So OSA is a disorder where breathing is interrupted during sleep, resulting in disrupted sleep, a low oxygen level in the blood, or both, estimated to affect 9 to 38% of the population. These diagrams here, you can see the typical airway is on the left, which is open and allowing air to flow in through the mouth and the nose into the lungs. And then the closed airway is on the right, where air can't flow into the lungs during sleep because the tissues of the throat have kind of fallen back and not maintained an open airway. Next slide, please. OSA is diagnosed through testing in a sleep lab or at home to identify obstructive respiratory events. So apneas are defined as complete cessation of airflow for 10 seconds or longer, and hypopneas are defined as a reduction in airflow of 30% or more for 10 seconds or longer, with a reduction in oxygen saturation of by 4% or more. And that count is called the AHI, or apnea-hypopnea index, and it classifies OSA as mild between 5 and 15, moderate between 15 and 30, or severe greater than 30. The oxygen desaturation index is also used, and that's defined as the count of desaturations. Next slide, please. The first line treatment for OSA is continuous positive airway pressure, which is an external device that creates a constant flow of air to support the tissue of the upper airway to remain open. You can see in that diagram, there's air flowing at pressure in through the appliance on the nose, maintaining the open airway. Next slide, please. So hypoglossal nerve stimulation is a second-line therapy with one FDA-approved device, which is the Inspire upper airway stimulation system. This device is implanted, and it uses electrical stimulation to activate the tongue muscles to maintain tone and move that tissue in the mouth area and throat area forward to keep the airway open. It also uses a respiratory sensing lead, so this is a wire implanted into the muscles in between the ribs to detect when a person is breathing to time the contractions of those tongue muscles. Next slide, please. So getting an HGNS requires several steps, and we'll go through them in order here. So to first qualify, you have to have moderate or severe OSA. The second criteria is that you have to be CPAP intolerant or that your CPAP did not eliminate OSA. And CPAP intolerant, as defined in the FDA label material, is an inability to use CPAP more than 5 nights per week or at least 4 hours per night, or they're unwilling to use CPAP, and did not eliminate means that they had an elevated AHI despite CPAP use. If you meet those criteria, then the next step is drug-induced sleep endoscopy. You've heard us mention this test before, but basically it's when a light dose of anesthetic is administered to mimic sleep, and then a flexible camera is used to inspect the upper airway to determine the anatomy, structure, and function of the airway and what's causing the obstructive sleep apnea. And those where the tissue is collapsing kind of all around the airway, called complete concentric collapse, they're excluded because of the potential for treatment failure, as in the hypoglossal nerve stimulator probably won't fix the problem. Next slide, please. So if you qualify up until then, you can proceed into implantation and adjustment. Implantation is typically an outpatient procedure with the device healed in place about 1 month after implantation and can then be activated. A follow-up sleep study is required to adjust device settings and optimize comfort, and the patient has a remote device controller to turn the device on and off. And the pulse generator has a battery that must be surgically replaced approximately every 7 to 10 years. Next slide, please. The FDA approval has changed over the years with some supplemental approvals you can see in this table. We'll dive a little bit deeper into that later, but currently the FDA approval is for moderate to severe OSA, for those who are CPAP intolerant or where CPAP didn't eliminate OSA, with no concentric collapse on the DICE study, age 18 years or older, and there's an upper limit of BMI warning at 40 due to unknown effectiveness or safety at higher levels, and have an AHI within the range of 15 to 100. And the approval expansions were based on non-randomized, non-comparative data from what we could tell. Next slide, please. So this is an update. So Inspire Medical Systems maintains a public directory of providers, and we queried as of August 2025. So we found one additional provider in the Portland area, so that brings the total to 7. The same in Salem, and the provider that was listed in Medford is no longer listed, so the Medford total goes to 0. There's a total of 18 listed providers across the state. Next slide, please. Okay, onto the scope. So which populations did HERC include? These were adults with moderate to severe OSA, excluding children and adolescents, mild OSA, and central sleep apnea, which is a distinct medical condition. Next slide, please. For interventions, again, we focused on hypoglossal nerve stimulation devices. Non-FDA approved devices were not included in our grade tables. Next slide, please. For comparators, we included non-surgical OSA interventions such as CPAP, no treatment, subtherapeutic stimulation, also called sham stimulation, or an inactive device, and we excluded airway surgeries and weight loss interventions. Next slide, please. For critical outcomes, Herc selected quality of life and device-related serious adverse events. And for important outcomes, Herc selected change in OSA severity, daytime sleepiness, and major adverse cardiac events. Next slide, please. For effectiveness, we included randomized controlled trials of any size and comparative prospective cohort studies of more than 100 participants. For harms, we included all those studies above, in addition, systematic reviews including non-randomized studies, single-arm prospective non-randomized studies of greater than 100 participants, and registry studies. Next slide, please. The key questions were about first was on the effectiveness of hypoglossal nerve stimulation, and then the harms, followed by any variation in the effectiveness and harms by intervention and patient characteristics. The contextual questions, which we'll dive a little deeper into later, mostly around expanding the sources of evidence for some key outcomes, looking at the comparative effectiveness of HGNS for OSA, and then the cost effectiveness of HGNS for OSA. Next slide, please. So we used our typical search and selection methods. We worked with an information specialist to develop a comprehensive search strategy using multiple clinical evidence databases and independent dual review of search results. For policy items, we conducted targeted searches in Ovid Medline and websites of related professional societies and guideline groups, as well as internet searches. All risk of bias and methodological quality assessments that you'll hear me present were performed by dual independent review within our group. Next slide, please. We'll present the certainty of evidence using the grade system, which you've heard me present before, I believe. It goes from very low, which is that one blue dot on the bottom, that the true effect is likely to be substantially different from the estimate of effect, to high, which is we're very confident that the true effect lies close to that of the estimate of the effect. And then outcomes where there's no evidence will have 4 empty bullets. You can see at the very last row. Next slide. So both of our clinical experts, we met with them regularly and shared feedback to inform our review. They participated in scoping, reviewed the list of included studies and clinical guidelines, reviewed our findings and evidence synthesis, and for this update, we met with them for any new evidence or guideline sources that we may have missed that they may be familiar with. In all these meetings, we presented our findings and offered an open discussion, and they're invited to participate in the meeting today. And again, I just want to say thank you both for your time in this process. Next slide, please. Okay, moving on to the evidence review. So here's the flow chart of studies. I just want to direct your attention to the lower left-hand corner, which is the included studies. You can see we previously identified 20 studies, and then we found 3 additional ones. And we'll go into depth which ones those are. Next slide. So we found 120 unique new citations in our searches. We screened 19 full-text studies and found 3 that are eligible. But again, these didn't really add any new information. There was the follow-up time was within the range of existing studies, and the device-related SAEs reported were similar to existing studies. But we included them in this presentation anyway. Next slide. So I want to take a moment to just take a step back and talk about how the devices were studied in RCTs. And this was, I think, a little bit of a point of confusion last time. So we're going to spend a few minutes on it. So this is different than a typical drug trial that you may be familiar with. And this is what the authors called a withdrawal RCT, or a randomized withdrawal study or trial. It kind of had a couple different names depending on who was doing it. So the first step is kind of a clinical one. So you identify patients who are candidates for the device, interested in having the device, and receive the device implantation. Then there's a period of healing and adjustment. And then there's kind of a separation at this point where patients who have a positive response and no removal can then go on to participate in the study. But patients who have a negative response or where the device is removed, they're not eligible to participate in the RCT. And the proportion of those who respond and those who don't is not quantified in any of the studies that we identified. So the people that are randomized are a selected group of people that had a positive response from the implant that was previously put in. And then once they're randomized to either keeping the device active or having the device be inactive or producing subtherapeutic stimulation, also called sham stimulation, which is just a low dose stimulation to make the person believe that it is effective, but it's at a dose low enough that it would not be anticipated to have significant effects on the tongue muscles. Within these studies, there was a lot of different measurements of outcomes, a lot of different comparisons that they would do. Some studies did a change from baseline. You can see that very long dashed line at the bottom. And then some looked at the difference at the end of the withdrawal period versus randomization, or the change during the withdrawal period compared to the change in the comparison group during the withdrawal period. So it got a little confusing, but we tried to tease it out. And again, a lot of that's more in the detailed slides that we presented to you last year. But if you want to go over any of that, we have that. Next slide, please. So here's the overall evidence summary for quality of life. We found we had low certainty that there was a benefit. Larry, yeah, I can take your question. So does the negative response or removal non-inclusion necessarily affect outcomes? I think that that's a question, and we don't know the answer to that because the study selected for patients who were already considered to have a positive response. So I think that that's a data point to be considered when looking at those RCTs.
Because I'm looking at that because when I read through the materials, I was looking at the revision and explant rates, and so I'm wondering if the non-inclusion initially does that affect the outcomes, and if it does, that's pretty significant or potentially significant.
Yeah, that's a good point. So I think that there's two things going on here. One is the RCTs that looked at effectiveness. To be eligible for that, you had to be considered a positive responder. So that is already a selected population. But then when we look at harms like explants and revisions, we included a wide variety of study types. So theoretically, that information should be representative of the population or more representative of the entire population receiving HGNS implants.
Okay, thank you.
Yeah. So for quality of life, we had low certainty of a benefit. For device-related SAEs, we had moderate certainty that we understood the scope and magnitude of revisions and explants, and low certainty that we understood the range of other SAEs, which we'll dive into in the next slide. For OSA severity, we had low certainty of a benefit, and for daytime sleepiness, there was low certainty of a benefit as well. So for harms, we divided these into revisions and explants, where we had better information, and other device-related serious adverse events. So the rate of device revisions ranged from 0.4 to 6.3% of participants, and the rate of device explants ranged from 0.05 to 2.4% of participants. For other device-related serious adverse events, these were a lot trickier to understand. Derek, I see your hand up. Let me just finish the slide, and I'll give you a few minutes to talk. Eligible studies varied widely regarding other reported SAEs, and we were unable to determine an overall rate or percentage of the SAEs based on reported data, although there was not always enough information to determine the precise level of severity of the adverse event. So for example, if a participant had an infection, that could be an infection treatable in an outpatient setting with oral antibiotics, which would not be serious, but if they were hospitalized and needed IV antibiotics, that would be serious, and we didn't always have that information to say one way or the other. Derek, if you had a comment or wanted to add some clinical input, that'd be great.
Well, I just wanted to comment on the question that Larry had, which was about the initial trial design. I mean, they focused on the responders because they were just interested to see specifically what was in these people that seemed to be responding well, what was the effect of withdrawing it? That seemed the cleanest way of looking at it. But most of the studies, there have been a number of non-randomized studies that have looked at response rate. And Marcus, you probably saw a lot of those. And it seems fairly consistent around 65, 70% of people would generally be considered a responder at the initial, like after just the initial sort of implantation and activation. But that's with a sort of more formal criteria for success of, like reducing their AHI by more than 50% and their final AHI being less than 20. And I mean, that does not mean that among the people considered to be non-responders that they had no improvement, just didn't quite meet that definition of success. Most people have some degree of improvement, maybe just not that like meeting that particular definition. And so it's important to take that all into context. Plus, there have been many, many non-randomized studies that suggests a fairly, consistent sort of response rate in that. Maybe not many, but like there have been a lot of them that I think did not get included in this review because of the, level of evidence requirements that suggest pretty good response rate. Uh, it's not perfect, and nobody ever said it was, but like but even the definition for response is relatively stringent. So, and this is not one that, for example, you would apply to CPAP or, efficacy of CPAP or compliance with CPAP, like all that kind of stuff.
Thank you. Yeah. I see another hand up. Is that Abby?
Yeah.
Yeah.
I have a question, which probably is a good question for Dr. Lamb. I'm just trying to understand the relationship between a revision or an explant and some of these serious adverse events, which I understand we can't totally quantify. When a patient has a revision, is that second procedure a lot higher risk, or is the risk when you have a revision mainly obviously patient distress, cost, etc.?
Um, Trying to think of how to answer that. I think it depends on the nature of the revision, really. I mean, most of the revisions that I have seen or read about, well, I mean, I only have personal experience with a couple of cases, I think, and those usually were because of defects in the like the sense lead. There was a period of time when they found that there's some of the sense leads that were being manufactured and um, some of those were defective and had to be replaced. And that carries some risk of like pneumothorax and stuff, but I don't think it's any more so than when they were initially implanted the first time. And having done one or two of those are actually fairly straightforward. And in the rare situations, and I think this occurred more in the earlier versions of the device, with the IPG was defective and needed to be replaced. That's a really straightforward thing of, just unhook the wires and replace the IPG box. And if you're not messing with the wires and the leads, that's very low risk. If you had to revise the stimulating lead that's wrapped around the hypoglossal nerve, that's a more involved dissection and puts more risk on the nerve. But I don't think it can all, I mean, it certainly can be done safely and without significant harm to the patient other than having to go through another surgery. And I haven't had to do that particular type of revision myself. I've only completely explanted one device for a patient that wasn't getting benefit and actually had physical discomfort from the device itself. And so that's why we removed it, and she wanted everything out. It was a little more complicated to take it out than to put it in because of all the scar tissue, but wasn't too bad. So, I mean, I guess I'm not sure exactly how to answer that question because it really depends on the nature of the revision and what the problem was that led to that. If it was a device malfunction, that was probably relatively straightforward to fix. If it was because of how it's sitting in there, or particularly if wrapped around the nerve and the placement of the nerve, that was probably more complicated and more involved, but doesn't mean that couldn't be done safely. It just is, longer OR time.
Thank you. That was helpful. And it sounds like the device does not necessarily need to be explanted if it is not getting the desired effect. That would be
Correct.
mainly based on pain or patient preference.
Correct. I mean, like,
Yeah.
I think I've only had one patient, and I haven't done a ton of these because my numbers are not huge, but I think I've only had that one patient ask me to actually take it out. There are probably more that aren't using it or not using it as much as you would recommend they use it, but I only have had the one that has asked me to take it out.
Thank you. Any other questions on this slide? Devin?
Yeah, I guess more just along that, following the same line of thought. How big are these things? We're just thinking about patients that,
Yeah.
if they don't end up using it, you have this thing sitting there for, I guess,
It's very much the same form
decades.
factor as a standard pacemaker. So about the size of a Zippo lighter. maybe a little skinnier,
Okay.
but very similar in terms of size and as a pacemaker.
And then the registry studies, the duration of follow-up we have on these devices is out because they're still relatively new. So how
Well,
long is our experience with
some of these
these?
registry studies go out more than 5 years, more than that now, 6 years. I can't remember. Marcus can.
Yeah, Shauna, maybe you can pull some exact details, but there's kind of two types of registry studies or retrospective studies that we looked at. There were ones that were more retrospective cohort studies that followed people for time, and then there were the big reporting studies like the FDA mod database or device reports or things like that that aren't really, you don't know the follow-up time. You're just aggregating reports of issues with the device.
I mean, this has been FDA approved since 2014, so there's actually more than a decade's worth of data that's like experience with patients. I don't know if it's all been like long-term reviewed and published, I should say, but it's now been on the market for a while and getting
Yeah.
marketed since before 2014 because like those initial trials that Marcus was talking about all occurred before FDA approval.
Yeah, that's correct.
This is Shauna. I can clarify that some of the registry studies that we look for, particularly those looking at the MAUDE database, were about 8 to 10 year collection period. So for at serious adverse events like explants and revisions, we have that kind of that window.
Yeah, and in that one, you're not necessarily following individuals for 10 years, but you're just collecting 10 years
over a
of
10-year period.
Yeah, it's tough. We didn't. Yeah, we kind of collected all as our general framework is for harms, you have to collect as much data as possible to detect harms that are more rare or more unusual. And so those studies were included as part of that approach.
And then do you have just kind of a descriptive sense of what some of these serious adverse events are?
I can start from the literature, and obviously it's highly clinical, so I would turn it over to Derek. But the most studies either would just report a category like total SAEs, that was what they were called, without really much specification. That when they specified it, the two biggest ones, the two most commonly reported ones were infection and pneumothorax. And when I say most commonly reported, I don't mean that they were common. I mean that the studies actually had them listed, the percentages listed. And again, for both of those, as infection I knew, but pneumothorax I was educated on, that they're not necessarily a serious adverse event because there are small pneumothoraces that do self-resolve, which goes against my internal medicine training, but that's why the surgeons do different things. Derek, if you have any comments on that.
I mean, obviously, pneumothorax has the potential to be a very serious thing and potentially life-threatening if it's not recognized, but it's pretty much standard protocol with these devices, and this is even recommended by the company itself to get a chest X-ray on everybody after the surgery, and you would detect specifically looking for pneumothorax. And if you find one that is clinically relevant, and I've had one that like was behaving like a tension pneumothorax, as long as you recognize it and deal with it, as you do with any normal pneumothorax with a suction drain, it is not a big deal. Although, I mean, it depends on how you define a big deal. Like that particular patient had to spend an extra couple of days in the hospital with the drain in place and then had to have it taken out. But he went home after that and was fine. Should also mention that we're sort of catching up with the times, but the latest version of the device now that the company is like, they're not even making the old device that has the sense lead in it. The latest version, the Inspire 5, no longer has the sense lead in it. So pneumothorax would really no longer be a risk with the newest version of the device because all it is the IPG and the stimulating lead, no longer any sense lead. So the pneumothorax risk would go away with the new device. That's just coming online, and I've been told that we have to use up the rest of the ones we have here of the old one before we can get the new ones. So we're right at the transition point for that. But for your guys' information, like specifically the pneumothorax risk, that would be going away moving forward.
Any other follow-up questions, Devin, or?
No, thank you. I appreciate that. I think, we just took care of a guy who, I mean, a different issue, but I think we have to really scrutinize devices in particular because um, the bar one needs to pass to have them approved is lower than it is for other things. And so, just having taken care of a guy, I mean, different subject, but advertised to have a removable IBC filter, wasn't removable at all, and ended up going through a 6-hour procedure and had a lot of morbidity associated with these things. So I think it's just important for us to think about what the most serious complications are and the timeline of them, and especially what's happening several years out. Are these things stuck in there? And what's the experience of those? So anyways, I appreciate the information.
Thank you. Next slide, please. So as I mentioned, a year ago, there was a recall of a limited number of Inspire devices. It was a class 1 recall, but it was limited only to 32 devices. They cited a manufacturer defect. At the time of that report, we didn't see any information on injuries or death, and we haven't seen any information on injuries or death or any updates on that recall. If those devices do have a malfunction or do have a result in a serious adverse event, that likely would not be reflected in the studies that we found, and it may come up in future studies. But we didn't find any changes with the status of this recall. Next slide, please. For contextual question 1, the key endpoints from systematic reviews, we didn't find any change with this, but the purpose of this was to broaden the search for key endpoints to add more types of studies that may potentially be less reliable. For example, systematic reviews, including a wide range of studies. We previously identified one systematic review of 17 studies that had some additional information on deaths. There were 7 deaths reported, but none were determined to be related to the HGNS device itself. And we didn't find any new information on this one. Next slide, please. For comparative effectiveness, we didn't find any change with this update. No eligible RCTs. Next slide, please. For cost and cost effectiveness, there was no change with this update as well. We previously identified an economic modeling study on the Inspire system. That study estimated healthcare costs from the perspective of a payer, and we extracted cost per outcome averted for HGNS, and we adjusted it to 2024 US dollars. There were several key assumptions about the impact on HGNS. There were several key assumptions about the impact of HGNS on outcomes, and that impact wasn't necessarily directly studied in the RCT, so it's using modeling assumptions. And the study did not use OHP reimbursement methodology to determine cost, so the applicability of it to OHP is unclear. Just as a reminder, to comply with Senate Bill 1508 of the 2024 Oregon State Legislative Session, we didn't consider quality adjusted life years or any similar quality of life in general measure. Next slide, please. So here's the results from that cost and cost effectiveness study. You'll see there's 2 graphs that are similar in structure. The left panel is a 10-year time horizon. So this is the cost per outcome averted. So in other words, the cost to prevent 1 motor vehicle collision was about $107,000. The cost to prevent 1 stroke was about $1.9 million. And the cost to prevent 1 heart attack, myocardial infarction was about $674,000. Looking over a lifetime time horizon, the motor vehicle collisions was about 88,000 to prevent 1. Stroke was about 6.5 million, and myocardial infarction was about 636,000. Next slide, please. For ongoing studies, there were no publications identified from the ongoing studies that we previously identified, and we didn't identify any new eligible ongoing studies for this update, so nothing new here. Next slide, please. So guidelines and recommendations. So there was no update to the FDA approval. As of the time of this review, Inspire UAS is the only FDA-approved device, and there have been no changes to the label since 2023. You can see in this table, again, you're familiar with the original approval in 2014 and the updates of the approval, the last one occurring in 2023. Next slide, please. The current FDA approval is, again, do you have to be CPAP intolerant or that CPAP did not eliminate OSA? There's no complete concentric collapse on DICE. Then there's no, they don't have central or mixed apneas greater than 25% of the total AHI. There are some exclusions, including anatomical findings that would compromise the performance of upper airway stimulation, any condition or procedure that compromise neurological control of the upper airway, patients who are unable or do not have the necessary assistance to operate the sleep remote, and patients who are pregnant or plan to become pregnant. Next slide, please. For clinical guidelines, we didn't find any changes to the recommendations. While there were new versions of the recommendations or the guidelines published, the recommendations themselves didn't change. So the VA Department of Defense, which we rated as good methodological quality, recommends HGNS as a second-line treatment. It notes the FDA criteria, but it doesn't make a specific recommendation on what should be used. The German Sleep Society published in 2022, and we rated this as poor methodological quality, and it's recommended as a second-line treatment with the range you see there. And the European Respiratory Society in 2021, which is fair methodological quality, they recommend against it. And NICE in the UK recommended that it should only be used with special arrangements. Next slide, please. For payer policies, again, we didn't find any changes to the coverage criteria, but we did sometimes find updated or republished policies. So Medicare in 2020 has an LCD where HGNS is covered for those 22 years old and older with a BMI less than 35 and an AHI between 15 and 65. Aetna and Regence are similar in that they cover for 18 years and older, although Aetna has a BMI upper limit of 40 and Regence is 35, but they cover the range of 15 to 100 for AHI. Cigna and Moda are also similar in that they cover for age 18 years and older with a BMI of less than 32 and an AHI range of 15 to 65. Next slide, please. So I'd pause here for any questions that folks have. If not, then we'll kick it to Ariel for the discussion portion, but be happy to take any questions or clarifications, any more information that I can provide. Devin.
And I'm sorry, I know you covered this. Can you just remind us the magnitude of benefit seen?
Yeah, we can go back to the summary slide, which is slide number 33. So we found low certainty of a benefit.
Okay, in terms of, but
sorry, low certainty of a benefit for quality of life, and then low certainty of OSA severity.
So just in terms of, OSA severity, I'm just trying to get at kind of a quantitative sense of AHI improvement and
Sure. If you want to, Liz, if you want to go to the supplemental slide starting on slide 63. Okay, so we'll just go through the more detailed data for OSA severity. So for this, we found 3 randomized controlled trials and 2 cohort studies for a total of 673 people. We downgraded the level of evidence or certainty of evidence for risk of bias and indirectness. So risk of bias, there was limited methods reporting possible selection bias, industry funding, and author conflicts of interest. And for indirectness, there were differences between the study designs. The study populations were more limited than the current FDA indication. And research participants were not necessarily generalizable to the greater Medicaid insured population. And the studies in general had short follow-up periods relative to the intended length of the intervention. That's just the limitations up front. In the next slide, if you want to go to the findings. So patients who received HGNS had significantly lower OSA severity indicated by lower AHI and ODI across all follow-up time points. This is HGNS versus control or no treatment. So you can see the studies there. Again, this is the withdrawal RCT, so it's a little bit confusing. So the first, you can see 0.6 versus 16.1. So 0.6 is the people that they left the device on. 16.1 is when they turned the device off or set it to subtherapeutic stimulation. So the difference is an AHI of 16 events per hour. The minimal clinically important difference is 5 events or greater per hour. So that all these exceed the minimal clinically important difference. I'll pause there if you have any questions about that.
Except the third one listed there, right? Just barely.
That's more than 5. Yeah. Third one. Sorry.
Less, but I mean, it's 5 basic. But
4.9, yeah.
yeah, sorry. Sorry, not to be, I just to, I'm
No,
going to
no, that
be,
was my mistake.
I'm going to
reported in
play the
the
role of a skeptic just
no,
for
no, no. In
sake
the
of
guideline,
argument. But
in the coverage guideline, it's correctly reported that there's three out of four meet MCID. That was my misspeaking.
okay, but so of the three trials, the longest duration trial did not quite meet clinically important difference threshold. So, kind of barely, 5 events per hour. Anyways, I just wanted to get a sense, partially because of the study design that you are highlighting, Marcus. So these are not intention to treat analyses. These are basically people that are most likely to benefit, and the longest duration trial in those most likely to benefit kind of barely showed a clinically important difference over 10 weeks. Do we know whether, and I guess, and I mean, the cohort study is reassuring in that the number was larger. Is there any sense that the benefit declines over time, that you're likely to see the greatest benefit initially and it kind of wanes with time, or?
We didn't find much information to that point. The studies that had so STAR had two components. There was an RCT, and then there was kind of a single arm prospective cohort study. And they reported that the effects were pretty durable. I think this is possibly a place where clinical experience might come into play. Derek, I don't know if you have any comments on durability.
Yeah, as a general rule, it seems like that if people are getting benefit from it, then that benefit seems to be durable. In fact, there were a number of published the Adhere registry studies. There were some quite long-term studies published based on the people in that registry, going out. The last I recall is out to 6 years. And those people generally had very sustained improvements both in AHI, and important to keep in mind too that what you're looking at on this slide is just the AHI, but that ignores all this quality of life measures as well. And those were all very positive in favor of the stimulation for these patients. But those benefits, whether it was AHI or quality of life, were all sustained for as far out as they could capture data on. Now, to be fair, some of those, the longer, of course, the further out you get, the smaller the sample of people you have data on, right? But it was still a pretty, like, I think it was still a pretty substantial proportion of the initial cohort of people that they started from. And so, and you would hypothesize that of people that they're able to obtain long-term outcome data on, that might even select for people that were having problems, because if they're doing well, they'd probably be harder to get a hold of to track. But in any case, the point is there is some long-term outcome data, at least from the initial STAR trial, certainly, which is and they published, I think, out to about 6 years afterwards. And those people did have sustained improvements. And generally, we do not see the need like there is the initial adjustment period where they have to have their device settings adjusted and whatnot. But once they find a stable setting, generally those settings do not have to be changed over the long term. Like, and that was one of the early concerns, was like, does the effect wane over time? Do we have to turn up the stimulation, et cetera? That doesn't seem to be what we find.
Thank you. And I would just say the single arm, excuse me, the single arm prospective studies, looking at people over time, those wouldn't be eligible for inclusion in this review because from an evidence perspective, they don't have a comparison group. So from the evidence framework here, we wouldn't be able to say what is due to the device versus controlled treatments or natural history or whatever. But I do think that information is valuable from the single arm studies, or can be valuable in this case, just as far as understanding.
Marcus?
Yeah.
So I have a couple of questions. I don't know if they can be answered, but my thinking is, what is the complication rate? How's it measured? Is it significant? How does the complication rate for this procedure compare to other similar interventions? And is there any type of risk benefit or cost benefit analysis? And I'm trying to kind of pick out that between from all the information presented, and I'm
Sure. I can take that in steps here. Liz, if you want to go to slide 34.
okay.
So here's the overall summary of serious device-related adverse events or complications. You can see that revisions were 0.4 to 6.3, and explants were 0.05 to 2.4%. The other serious adverse events, we really didn't have any data. And now I'm talking from the research and the studies that were eligible and that we reviewed. We didn't have any data enough to say what percentage of people have other serious adverse event or what percentage of people have a complication.
Yeah.
So that's where Derek has been helpful in letting us know the clinical experience. Then the question about the complication rates, and I'm not a surgeon, so I couldn't tell you how it compares to other procedures. But if anyone has any information on that, feel free to comment.
And then I'm also looking from a economics perspective, cost benefit or risk benefit type of analysis.
Yeah. Before I jump there, Derek, did you have anything to comment about comparing the implant to other procedures?
Well, I mean, there are no other implants like this for this disease process, right? Like, I mean, the closest comparator is probably like a vagal nerve stimulator, but that's in a particular, those are for like people with uncontrolled, epilepsy or what have you. Like that's a different patient population. Um, I can tell you that if you're comparing this to like other forms of sleep surgery, like they're just apples and oranges. I mean, because this is the only implanted device for this purpose, and the recovery is really not bad. Overall, as you can see from these numbers, the rate of adverse events is actually really low. It's an outpatient surgery. People don't have to stay in the hospital, so like, I think it's.
Does this involve general anesthesia?
Oh yes, it is under general anesthesia for
So
sure.
there's an additional risk from general anesthesia.
Sure. I mean, yeah, no question for that. But it's an elective thing, so everybody has to get screened for their safety for general anesthesia. And if they're considered not safe for that, then they just don't get this, or they get optimized to have general anesthesia, right? So yeah, but the length of the procedure, I mean, this is not like a spine surgery, right? Like it's probably from between 45 minutes to an hour and a half, depending on the patient. Like, so these are not long procedures, and getting shorter with the new device that doesn't have the sense lead, it could be as short as 30 minutes. So, it's as the procedure goes, it's actually quite safe, and recovery is not bad either. Relative to other things. I don't know. It's hard to put that in context because again, we don't have any other devices for this.
Thank you.
Although there are soon to be a few other competitor type devices coming out in the next few years. So pretty soon it is not going to be just Inspire. There's at least 3 other devices that Marcus alluded to that are getting in multi-center trials and probably going to get FDA approved in the next couple of years.
Thank you. Does that answer your questions on complications, Larry?
Yes and no.
Okay.
And the no part is that when we look at the adverse events that are associated with this procedure, it's not just the device, the procedure, the implantation. Is there a revision necessary? Is there explant necessary? But it's also the fact that this is a surgery that involves general anesthesia and all the other complications potentially that come with any type of surgical procedure.
Yeah, absolutely. And if any of the studies reported a serious adverse events related to an operative or intraoperative complication, we would have included that, or we would have found that, and you can find the full details for that in the report, if it was reported in the study, certainly.
Okay.
Going on to your cost and cost effectiveness question, that would be slide number 38, Liz. So we found this one study, it was an economic modeling study of the Inspire system. They estimated costs from the perspective of a payer. And so we just calculated the cost per outcome averted, so cost per motor vehicle collision averted, for stroke averted, and for heart attack averted. Just want to make it clear that reducing strokes, heart attacks, and motor vehicle collisions, that's not been proven in any RCT of Inspire. It's an economic modeling study based on assumptions. So next slide, please. So you can see here the 10-year time horizon, the cost per motor vehicle collision is a little over 100,000, stroke is 1.9 million, and MI is a little over 600,000. The lifetime time horizon, you can see the thresholds are somewhat different. Any questions on this one?
I know that not getting enough oxygen when you sleep and not getting restful sleep makes people crazy. So
Just calling
Yeah.
attention to time, we do have another topic to discuss today, so let's try to
thank you.
make sure we're focusing the discussion.
If there's any other questions, I'd be happy to take them. Otherwise, I think Ariel, I'd pass it over to you.
You're muted.
You're muted.
I'm talking away. Liz seemed to do what I asked. I'm like, can you go to the discussion slides? She did. All right, next slide, please. So, the staff recommendation, and you all heard lots of caveats that Marcus was indicating. So there are some concerns about the structure of the different underlying studies that were part of the available literature. But taken at face value, the available literature does show that these devices appear to reduce apneic events and increase quality of life. So based on that, the recommendation is to cover the hypoglossal nerve stimulator, HGNS, for adults age 21 and older when they've had a sleep study within the last 24 months showing an AHI of 15 to 65 using a 4% oxygen saturation threshold. That's an important little detail. And a predominantly obstructive events, a body mass index of 32 kilogram per meter square or less, and not responsive to CPAP therapy, defined as using CPAP, inability to use CPAP for more than 4 hours per night, 5 nights per week, or a lack of adequate response to CPAP therapy, which is defined as an AHI-4 of greater than 15 despite CPAP usage. And having had a drug-induced sleep endoscopy with finding consistent with the absence of concentric collapse of the soft palate, and no other anatomical findings that would compromise performance of the device, and no other contraindications. So these are the most conservative of the coverage criteria that you saw. Again, given that there appeared to be a signal for benefit, but a little bit uncertain based on study design. Next slide, please. Oh, I'm sorry, Devin, did you have a comment?
I can wait until you're done.
Okay, next slide, please. So the rationale is there appeared to be an improvement in sleep-related quality of life and OSA severity that outweighed the risk of the procedure in those selected patients with, certain HIs, certain BMI, etc. And the coverage criteria that was included is consistent with the inclusion criteria in the reported studies and informed by certain Medicare criteria. Next slide. We have low confidence. There's a clinically important improvement in sleep-related quality of life and sleep apnea. The degree of confidence is low because the included studies have a high degree of selection bias and indirectness. And additionally, that somewhat unusual study design of only enrolling patients with an initial positive response to the HGNS. We have low to moderate confidence that the full scope and magnitudes of harms are known. And overall, these benefits appear to outweigh the reported risk of harms. Next slide, please. Research allocation. HGNS does require a high level of resource use. A patient would need to undergo a drug-induced sleep endoscopy, which is a procedure that requires some level of anesthesia. You would need a surgery for the implantation and then follow-up sleep in-lab sleep studies. And then there's long-term maintenance anticipated for the HGNS system. Patients who have HGNS would likely need to continue CPAP therapy if they are tolerating CPAP. So you are not going to see a lot of cost savings from CPAP discontinuation. And the economic modeling study did not identify net cost savings in reduction of OSA complications, the stroke, myocardial infarction, and car crashes, with the caveat that Marcus called out that these were hypothetical. They weren't actually seen in the studies themselves. Next slide. Many patients who have not responded to first-line OSA therapy, particularly CPAP, would value a second-line treatment that would improve their sleep-related quality of life and reduce their symptoms. However, other patients would not want an invasive surgical procedure, particularly if it doesn't have a dramatic reduction in their symptoms or eliminate the need for daily CPAP usage. Next slide. The other consideration is there's not a lot else out there. There is the UPPP and tonsillectomy that you saw coverage guidance about. Those are also only for selected groups of patients, and then CPAP. There's not a lot of other therapies out there currently. Next slide. Yep, that's all. Devin, your questions. Liz, why don't you put up the first of the discussion slides in case we want to reference them?
Yeah, on the coverage guidance. I mean, I think generally it's probably along the right lines. Couple of things. One is that I believe, and I haven't looked at this data in a little while, but I believe that CPAP desensitization protocols are fairly successful in a decent proportion of patients who initially report intolerance to CPAP. Again, I don't know the numbers offhand.
For the UPPP, the final guideline that was approved by HERC, it's a little different than what you all approved here. There were additional criteria. You had to have had a visit with I can't remember the wording, but essentially you needed to have a sleep specialist, a sleep technician work with you on masks, et cetera. There was some additional wording there that we could also look at for this if desired.
Yeah, I think that would be important because I think we're talking about a really large number of people, because the number of people getting sleep tested is huge. And the number of people who initially say they don't tolerate CPAP is large. And I do think there'll be a chunk of those who, with additional trials, can end up tolerating CPAP. So I would favor doing that. And then the other question you've already answered because there's a BMI criteria in there. So never mind.
Larry, I see your hand up, but Derek, did you want to respond to Devin's question before we take Larry's question?
Yeah, I feel like there was this was brought up last year when this was discussed at the same meeting about the potential for I think there was a concern about opening the floodgates of people wanting to get implanted. And it is certainly true that there are lots of people that do not tolerate CPAP. I don't know how, I guess it's beyond my experience or expertise to comment on how successful the desensitization protocols are. But I think that to me, it seems unlikely that there will suddenly be a huge push of people to get implanted because for one thing, I mean, there's only so many providers for this in the state. It actually requires a fair amount of infrastructure and coordination between the surgeon that does it and the sleep medicine docs that are going to follow these people. Like you have to have all that there. And so there's sort of already a fair amount of built-in friction, so to speak, before patients can really get implanted and do so successfully. And so, I mean, yeah, and the other thing is that with the current these current recommendations, particularly the BMI cutoff, these are the most conservative and restrictive of I mean, like these were the same as what was initially FDA approved. And I remember I had started implanting when under these guidelines, and it was actually uh, quite a challenge for people to be under 32, a BMI of 32. When they lifted it to BMI of 35, that then there was a much bigger pool of people. But if you think about it, people under with a BMI under 32 who also have bad sleep apnea, that is cutting out a significant chunk of the people that might otherwise want to get implanted. And that was actually one of the early frustrations of trying to being able to offer this to people because I would have to turn them away and say, go lose 50 pounds or 100 pounds or whatever it is, and then you can come back and talk. I actually think personally that 35 is about the right cutoff because 40 is just too much. Like people with a BMI of 40 or 39 or whatever, I think are going to be less likely to be successful. But 35 seems reasonable. But I totally understand you guys wanting to stay conservative with this recommendation to start, but that's going to limit the pool of potential people that could get implanted. That alone actually is going to limit people as well.
Thank you, Dr. Dr. Lamb. We really need to move along. It is almost 4 o'clock, and I want to see if people are ready to take kind of a straw poll on moving this forward or not. I think we need to limit our discussion or we won't get to our next item. Um,
And just to respond back
and
to
we're
Devin's point, we
and
don't
we're
need to
losing
change
people.
this
Yeah.
for the additional sort of like, trying to tolerate CPAP. We could do that in a guideline in the prioritized list.
I'm having a little bit of cognitive dissonance with this because what percent of patients who have this procedure have to also go back to CPAP? Because if the procedure doesn't alleviate the need for the CPAP, and there's desensitization for CPAP, but we don't know the statistics on that. I'm not comfortable making a decision on this.
Well, I think the opportunity right now, Larry, is to take what we have in information and kind of take a straw poll. As Leslie's popped off and Kat is popping off, we're quickly losing quorum. So
Okay.
I think there's an opportunity for us to just take a straw poll. So Jason, would you be able to do that? We, kind of a thumbs up, thumbs down, move it forward, or um, keep
Yeah, I
it
guess since it's not a vote, there's no motion. As I call your name, if you could just say, leaning cover, leaning not cover, leaning to modify the staff recommendation in some particular way, but keep it very short. That would be great. So start with Larry.
I'm going to say no for now. I really want more information and yeah, I'll leave it at that.
Okay. Mimi,
Leaning towards coverage with staff recommendations. Thank you.
Abby,
I am leaning toward coverage and support the staff recommendations.
okay. Sorry, the names are flying around. Devin.
Yeah, also leaning towards coverage, and I looked up the proportion of patients that are able to become tolerant after mask optimization stuff, and it looks like about a quarter, an additional 25%.
So there'd still be some gaps there. Okay, and Linnea.
I'm leaning away from coverage. So I'd like us to have more information or come back with further narrowing and staff guidelines before moving forward.
So narrower coverage.
Yes.
Or we
if
could,
there's-
Linnea, come back with a recommendation against coverage if that's
So
where you feel we
one
should.
way to get that information, whatever's available, we can't make information that's not available, is to, and we've done this in the past, would be to recommend non-coverage, get the public comments in writing so we can review those at our next meeting in February. And I think staff has done what we can within our scope statement, so I'm not sure. So consider that an option.
I would lean towards that, I think then. But I also know that out of the five of us who are here and voting, three have recommended. So want to be acknowledge where the majority is.
Right. So does anybody want to make a motion based on that?
I mean, I'm not sure that the evidence is going to change at all. You know, I, I,
I agree with Devin. I don't know that the evidence is going to change, but I would like some more information.
Well, if you're not comfortable, if you don't feel like you're convinced by the evidence, you could vote for non-coverage, and then there may be public comment that you could take into
It could be
account.
public comment either way, right?
So I guess I'm not sure if I am allowed to make a motion towards coverage.
You can make
So that would
any
be
motion you want.
probably adopt the staff recommendation. I think that's already on the table.
To adopt the
Abby-
staff recommendation with, I mean, as you said, Ariel, personally, if there's something in the guideline note about the attempts at, desensitization and stuff, to optimize CPAP use, but otherwise I would be supportive of the staff recommendation.
So are you moving with the
And
modification to
moving
add a
in that.
requirement for,
Well, I may have
friendly staff
misunderstood Ariel.
modification that we could do that as part of the guideline process that would go through VVBS later.
Yeah.
So
I don't feel like it has to be in this blue box, but if Ariel says that you can kind of reconcile that down the road, that's fine with me.
so this motion would be what you are proposing to put out for public comment, just to be clear. So you
Yeah.
are voting to put the staff recommendation out for public comment with the understanding that there may be criteria around CPAP optimization as a part of a guideline later in the process.
Yeah.
Do I have that right?
Yeah.
Is there a second to that?
I thought I heard somebody
I'm
motion
sorry,
for the staff.
could you, I apologize. Would you make the proposal one more time? Or the motion?
I move
Sorry,
to
Devin.
put the current staff recommendation as worded out for public comment with the acknowledgement that the additional stuff around CPAP desensitization
Can
will
be addressed at a different
addressed
format.
in the future guideline.
Oh, I second that. This is Mimi.
Can we call the roll?
All right. Let's see. Mimi,
Approve.
Larry,
Disapprove. I think we need more information before sending it out for public comment.
okay. Devin,
Approve.
I'm sorry, I lost track. Who did I miss?
Me, Abby, approve.
Abby. Thank you, Abby. And me, Linnea.
I'm neutral.
So yeah, we in order with five
Yeah.
people
So
here,
I'll
we
say-
need 5 votes in order to have an action. So we need
I'll say no.
okay, so that was really 3 no's and 2 yeses. So there's no action.
I thought it was the other way around. Mimi and Abby and Devin all said yes. And
Oh,
Larry
thank you.
said
Thank you.
no.
I'm sorry. I'm trying to do too many things at once here.
Yeah, want to be clear. I knew where it was headed. So thank you.
Okay. So with that, then the motion carries and it will go out for public comment and we will have further discussions in February. So let's move on to the scope statement.
Thanks, Jason. So we are going to present to you a scope statement to look at traditional versus disposable insulin pumps for type 1 diabetes. We wanted to just go over a few grounding slides since this technology is changing pretty quickly. So I'm just, in the interest of time, I'll spend just a couple minutes on those slides, and then we'll move into reviewing the scope statement. Liz, are you able to put up the slides?
Yes, just 10 seconds.
No problem. Thank you. So next slide, please. So very brief overview of diabetes. There are multiple different types of diabetes. We are solely focused in this scope statement proposal to look at type 1 diabetes. It is a very serious medical condition. Frequently, it is an autoimmune response that destroys pancreatic cells, and so people are not able to produce insulin, and that is essential for moving sugar into cells. So those individuals are at risk for a lot of complications and a lot of tissue damage over time that is both acute and chronic and can lead to a number of other conditions as well. One of the things that is important for this conversation is that people with type 1 diabetes can move into what's called diabetic ketoacidosis, which may land them in the emergency department or the ICU as they begin to burn fat instead of glucose if they can't move it into cells. So we'll talk about why that's important for the scope statement in a few minutes. Next slide. So in order to treat type 1 diabetes, people with that condition need insulin administered out from outside their body to actually allow their body to use the glucose and move it intracellularly. So that in the past has happened via multiple injections throughout the day, different types of insulins, which is out of the scope of today's conversation. So a new advancement a number of years ago was the insulin pump, where people then weren't doing multiple daily doses of insulin, but were using a pump to administer insulin, sometimes at a basal, meaning a regular rate, and then adjusting boluses for or another bump of insulin for particular things like eating and exercise, infection, and other things. So we're looking at this insulin pump focus, not on the multiple daily doses of insulin or the devices that are used to deliver that type of insulin. Next slide. So these are some pictures just to give you a visual that will hopefully give you some grounding for the scope statement we're going to talk about. So traditional insulin pumps are connected by tubes. So you'll see that the tube is connected to a device which has insulin in it and pumps the insulin out as it's programmed. And that goes in through a device that attaches to the skin and puts a small needle into the subcutaneous or layer of fat underneath the skin. So that is the traditional pump. Oftentimes those are called tube pumps or tethered pumps. So we just want you to have the vocabulary because that's important for the way we're going to try to look at the evidence. Next slide. That's contrasted with the disposable insulin pumps, which do not have tubes or tethering. So those are often called patch pumps, micro pumps, tubeless pumps. Those can be attached to the skin, but there's nothing attaching them to the device that tells it when to actually do the insulin administration. You'll see that this still delivers insulin into the subcutaneous layer of the fat underneath the skin. So very similar location, but they're not tethered to the device that has the insulin and tells it when to deliver it. Next slide. So we want to talk just for a moment about continuous glucose monitors. So they're also called CGMs. Those are also wearable devices. There's a lot of press about them for lots of different reasons right now. Just reminding you again, we're looking at type 1 diabetes in this context. CGMs in the context of type 1 diabetes track glucose levels in real time. And so frequently they'll auto push to a phone device or a mobile device, or the device can be put close to the CGM to upload the actual numbers. But the person is more able to track their real-time glucose. CGMs are covered by OHP, but that is not in the scope of what we're talking about today. We're bringing this to you today because there's sometimes a discussion of insulin pumps and CGMs together. Depending on the device, there are different degrees of integration between those insulin pumps and CGMs. So we've listed out 3 types here. So there's an open loop system where the insulin is manually delivered. There's a hybrid closed loop system where there's automatic adjustments based on what those glucose numbers are. And again, those boluses could be required manually for things like adjustments of eating or exercise. And then the fully closed loop systems aren't commercially available yet, but we wanted you to have a scope of what's happening currently in this landscape. Next slide. So traditional insulin pumps, including some which integrate with CGMs, currently are covered for type 1 diabetes, and that is not going to be part of this review. According to OHA, the disposable pumps and their supplies are more costly than the traditional pumps and supplies, and currently they are covered by exception only. So to be covered, a device must be the least costly, medically appropriate item that meets the medical needs of the client. And therefore, HERC staff are proposing a review of the evidence, clinical guidelines, public testimony, and coverage policies given the frequency with which exceptions are needing to be reviewed for the disposable pumps. Next slide. So why use a coverage guidance as opposed to an issue summary in this case? In general, there could be potentially some mixed evidence requiring some closer examination. Insulin pumps are a pretty resource-intensive service and device. Increasing exception requests, as I previously mentioned, may indicate a need for policy guidance in this space. And covering of insulin pumps is within the scope of the HERC authority, which is why it is coming to you to review a potential scope statement. Next slide. So the current scope overview focuses on disposable versus traditional insulin pumps only for type 1 diabetes. We'll walk through the entire scope statement, but we're limiting studies to direct comparisons. And for efficacy outcomes, we usually include the usual study types will be included, and we've explicitly listed that out in the scope statement. For harms, there are a wider range of study types because you need additional data about harms. And so we need to have a more data gathering in order to sufficiently provide information to you about harms once this is complete. Next slide. So lots of different designs for different questions. So the first talks about effectiveness, and you'll see in the scope statement, we have a number of pieces around effectiveness that looks really at the cause and effect here. We really try to look at high quality studies. Harms, as I mentioned earlier, just a moment ago, may have a wider capture of the studies that we need in order to have a longer follow-up period, have them be largely representative of the sample, and be able to capture those more rare events, the more serious adverse events that we definitely need to know about as we consider potential coverage. Next slide. So Mark has already talked a bit about this in the HGNS presentation earlier about the next few slides. So I'm going to not talk about them in a lot of depth so we can move to look at the scope statement, but a comparison group is really important when we're looking at a cause and effect relationship. And in this case, you'll see we really were careful about thinking about how to compare the different potential devices in this situation. Next slide. And then I've alluded to this a few times, and so did Marcus earlier in the other presentation, but in order to capture harms, we really need the larger sample size for more rare events. And so we have a couple of outcomes that we wanted to ensure were included in this review so that we could ensure that we're catching all potential harms associated with this particular device. Next slide. All right, so just really quickly, what if there is limited or no evidence? So again, this is a scope statement proposal, so we actually don't know the full universe of evidence we may find. So Oregon law requires HERC decisions to be based on peer-reviewed scientific evidence. If there are few or no relevant studies identified, the finding would still inform HERC deliberations because it would describe the current knowledge base. And coverage guidance is also contain information on clinical guidelines and then other insurance coverage policies, which you will also see in this proposed scope. And as we referenced earlier in one of the first few slides, we can receive testimony from clinicians, OHP members, families, caregivers, and advocates. Next slide. All right. So let's go ahead and move over to the scope statement, which Liz has up on the screen. Before I do that, I just want to pause. Are there any clarifications about those grounding slides that I just presented?
No, that was a great presentation.
Okay.
Great.
Thank you. All right, so just moving on to the scope statement here. I know that you have seen it, but I want to be sure that we have a chance to just review it in detail before we deliberate about it. So the population description is children up to age 21 with type 1 diabetes and adults with type 1 diabetes. Population exclusions are people with other types of diabetes, including gestational diabetes. So again, just making the point, this is narrowly focused on those with type 1 diabetes only. The intervention we're looking at is disposable insulin pumps. Again, multiple other names which were in the slides and you see there, patch pumps, micropumps, tubeless pumps, and no intervention exclusion. This was an amendment that we made after on the second, after additional review and obtaining some other comments and discussions. Comparator here, traditional insulin pumps, also called those tubed or tethered pumps, which you saw the picture of. Comparator exclusions there are non-pump delivered daily doses of insulin, comparison groups with different modalities for glucose measurement, and comparison groups with different types of integration or automation. So basically, what we're taking out is anyone who's taking multiple daily doses of insulin in the study, regardless of how that's delivered. If it's delivered by pulling insulin up through a syringe and then administering it one by one, or via a pen, which may include an auto pen device, all of those are not here. Those are comparator exclusions. Additionally, we're also not looking at other types of glucose measurement. And the degree of integration and automation goes back to the integration of continuous glucose monitoring in a device, as well as the automation of how the insulin is delivered. So we really want to compare apples to apples here and have it be a pure comparison so that we know we're looking at the insulin pump, the evidence around the insulin pump, rather than evidence around a pump and another sort of device that's potentially interfering with the pump by itself.
Quick question. Can
Yeah.
either the tubeless or traditional can either have a integrated continuous glucose monitor?
So, yes. So we had spent quite a bit of time with our colleagues at CEBP who iterated this with us, looking at the potential combinations. So, tubeless, tubed, continuous, and that level of integration. Some of them have automated integration from separate devices. So we did take a look at that. Marcus, I saw you come off video, so feel free to jump in.
Yeah, if I can add a little bit there. So in general, we want to compare like to like. So we want to focus on disposable to traditional. If it's disposable, that's highly integrated versus traditional that's not integrated. That's not really a like to like comparison. It's not an apples to apples comparison. Yeah.
Very good. Thank you.
All right, so moving on to the outcomes, you see 5 here. So for critical outcomes, diabetes quality of life, and we had that limited to a maximum of 2 validated measurement scales. Serious device related adverse events, such as a device malfunction or failure, and then acute care utilization, so an emergency department visit or hospitalization. We considered important 2 outcomes of glycemic control limited to change in A1C or hypoglycemia of level 2 or greater. And that's a level of severity of hypoglycemia. And then the device adherence and discontinuation. Considered but not selected for the grade table, which you will recognize as a way that evidence is presented in the coverage guidances, are the list of conditions to the right. So we know those are complications of diabetes over time, but those are not considered for this particular grade table review of evidence. Study designs and data sources. So for effectiveness, we're looking at randomized control trials and prospective comparative cohort studies. For harms, again, I talked about how we are looking at additional types of studies so that we can capture all the potential harms, needing more time and more volume of number to catch more rare events, so that you see the list of what we may include there with the scope of this particular review. Study design exclusions are systematic reviews, and that's because the eligible component studies would be included in this review. So we wouldn't just be looking at the systematic reviews, but the individual component studies within those, retrospective cohort studies for effectiveness outcomes, and then case series and case reports. The follow-up for the studies that we're looking for would be at least 12 weeks or longer, and the study setting would be in the United States or similarly positioned countries with regard to the UN Human Development Index. No limitations on publication year. So the coverage guidance key questions are listed below. For effectiveness, we're looking at the effectiveness of disposable insulin pumps compared with traditional insulin pumps solely in patients with type 1 diabetes in this review. What is the effectiveness of disposable insulin pumps compared with traditional in type 1 diabetes based on age and impairment or inability to self-manage diabetes? So there are conditions in which a tethered pump has been shown to be more challenging with regard to the outcomes of interest as compared with a different population. Harms, key questions. What are the harms of disposable insulin pumps compared with traditional in type 1 diabetes? What harms for disposable insulin pumps have been reported in non-comparative studies or FDA medical device reports? And then are there current device recalls for any disposable insulin pumps? And then ongoing studies, what are the ongoing studies that could potentially meet inclusion criteria so that we have some situational awareness around what is coming forward in the next short term and a bit longer term. Clinical practice guidelines may also be reviewed. What are the recommendations from the US and the International Clinical Practice Guidelines 2020 or later? And you'll note the countries for which the clinical practice guidelines may be reviewed. We want context for the Oregon Health Plan. So what are the current OHP coverage criteria for insulin pumps for type 1 diabetes, which I briefly reviewed the current in the slides, but this of course will be a longer coverage guidance timeframe. So we'll revisit that. And then what is the OHP reimbursement for traditional insulin pump treatment versus disposable pump treatment if covered? And then other coverage policies are listed. So as something for potential review. So the 6 that are listed there, you'll see 4 commercial plans listed among the 6. So that is a brief flyover of this scope statement proposal. So I will open it up for clarifications and or discussion.
That was a great presentation.
Thank you. Looks like Devin.
Yeah, thanks, Heidi. That was very clear. So just one question in this kind of comparative effectiveness review. I assume that we wouldn't want non-inferiority margins, right? You're looking for superiority of the disposable pumps over traditional pumps because of the cost issue.
Right. So I think at this point we're covering traditional. So is there a reason to cover disposable pumps in place of, and that's why we want that peer comparison. But Marcus, I will also pass it over to you. Thanks for.
Yeah, thank you. If there was a randomized trial that was a non-inferiority design that otherwise met criteria, it would be included, and those results would just be synthesized along with the other results. And then
Sure.
a summary measure of effectiveness, would be presented to you all to make that decision.
Yeah. I guess that makes sense. I guess I'm just thinking ahead that I think for our decision making, we'd ideally want to see that it's better than not equal to, right? If it costs a lot more, but
And I think that's also why there's a particular focus on age and then individual populations, because some of the exceptions that have been seen more prevalent are certain groups for whom a tubed system may present significant challenges.
It seems to me
Yeah.
this is just a progression of technology.
Yeah, I mean, this technology is changing quickly. I really had to study myself just to understand even the scope of what's happening here. Errol, I know you were going to say something.
I was gonna say there are pros and cons to all the different types of pumps. So for some people that might be better and for some not.
Any other deliberation?
Just looking at the outcomes, I'm wondering if there's anything else that should be included. The implantation of the tube versus where the pod would go, is there any significant difference in procedure or anything like that? Or are any potential adverse outcomes in terms of installing a tethered pump versus this pod pump?
The way, go ahead, Marcus.
No, you go first, or I can.
I was just say the way it works in practice is that it's, self-administered if it's a child, obviously caregiver administered, but it's going in a very similar location. So the tube is literally the connection of either the disposable patch pump that's like up against the skin or the smaller area of the traditional pump that doesn't have the insulin contained in it, that's just in that same area. So they go into the same area on the skin, this generally the same parts of the body. It's just that that tube then connects to the other device piece rather than having like a more remote device. And I don't know, Marcus, if you have other things to add.
Yeah, I was just gonna reinforce what you said in our research on the different technologies. We didn't find any information that the complications or procedures or anything was drastically different between the two.
Okay, thank you.
They look pretty similar in real practice. So, Linnea?
So I'm thinking about there are certain populations where having a disposable pump might be um, useful. And I think just as long as we can make sure that as we're going through this, we listen to those potential exceptions. I'm thinking about people who are differently abled, who are potentially wheelchair bound, those kinds of things where, having a device attached, is not as easy to carry, or they don't have the limbs, or, there's all kinds of things that I can think of that could be exceptions to care. And just as long as we're making sure we are noting that, uh, if it's indicated, I'm with Devin that if we're not seeing superiority, if we're seeing equal, are we making sure that if we don't move forward with this, but that we create or allow for a lane line for people who may need it as an exception?
And I think from a staff point of view, that would be a really valuable outcome from this, is if we could come up with, if in general, maybe this is more expensive, but for this population or that population, that that would be helpful for OHA to define those populations.
Do people ever lose, since it's not attached, do people ever lose the controller?
You mean the remote device that is
Yeah,
used to tell
yeah.
it? Yeah, I don't know.
The other thing I'm thinking of is someone could divert the pod to actually pump in something other than insulin.
In our evidence search for adverse events, serious adverse events, we would certainly collect that information if it led to a serious adverse event.
Okay.
So in the vein that it is getting late in the day, and Heidi, Dr. Gullett, you did a fabulous job presenting, and I do think this is something that is up and coming, and it's on our radar for a lot of us, just because of the knowing type 1 diabetes is a concern. Are we at a point where we feel like we have enough information to decide whether to move this forward or not, or take the next step? Do we want to do a straw poll, Jason?
We can do that. Uh, let's go ahead. Abby, calling you first this time.
I would support moving it forward.
Okay, Mimi,
Yep, I support moving this forward. Thank you.
Devin,
Yes.
wait, did we lose somebody? I'm missing. I'm just seeing.
Kat had to step away, or
Leslie did, but we had 5 and I'm only seeing.
Where's Larry?
Oh, Larry, maybe he's on the phone. Larry, are you there?
He was here just a minute ago. I think it must have dropped.
Okay. Let's give him a second. Oh, he's texting me. Um, does this sound appropriate for the scope of this question for the staff to go look at this? My answer is this sounds great.
Sounds like a yes.
Yep.
And then Jason, I think it's me.
Yes,
Number
Linnea,
5.
sorry.
So I will, no, it's okay. I'll say yes. And I see that as unanimous between the 5 of us.
Okay, I'm
So
going to put Larry on speaker so if we have an official vote, he can actually vote. Larry, are you there? Can you hear Larry in the room, in the Zoom room?
No.
No.
No, we
Let me
cannot.
switch my microphone. Hang on just a second.
I don't think he picks up on your headset.
What about now? Go ahead. Go ahead, Larry.
Yep. Can you hear me now?
Yes.
Yes.
Great.
Okay. So is the question, is this the appropriate scope to go look at this question? My answer is yes.
Great. So I think sounds like somebody could make a motion to that effect. Then.
I'll move. Any,
I move that this be the appropriate scope to go look at this question.
I'll second.
All right. Call the roll. Let's go with Abby,
Approve.
Mimi,
Approve.
Larry,
Yes.
Devin,
Approve.
Linnea.
Approve.
All right. Motion carries. And then our next meeting is not until February. So I'm going to wish you happy holidays, including Halloween for those who celebrate. And a little earlier than I usually wish that this year. And I'll see many of you at HERC between now and then. But
Very good.
Thank you, everyone.
Thank you.
Thank you all.
Thank you.
Thanks.
All right, take care. All right. Bye-bye.